Welcome to this very special long COVID expert panel Q&A. We're just going to give it a few minutes as I can see lots of people are joining us. So today's session is run by Nottingham Hospitals Charity in association with the NIHR Nottingham Biomedical Research Centre. Hello everyone, I can see lots of people joining. My name is Claire Reynolds and I'm Head of Marketing and Communications at Nottingham Hospitals Charity. We are really pleased to welcome you all today to talk about all things long COVID. Whether you've experienced it yourself, whether you know a friend or a family member who has it, or simply if you just have an interest in the condition itself. As I say, I make it just gone at 5:30 UK time, so we will kick off in a few minutes. But I'm mindful people are joining. We might get a few more attendees arriving over the next 5 minutes or so. Just some quick housekeeping elements before we begin. We have had lots of questions from you sent through by email over the last couple of weeks, so we are going to start with those. But if you do have a particular question or something occurs to you throughout this evening's event, please do use the Q&A box, should be at the bottom of your Zoom, and we'll add that to our schedule if we have time. If you can't find that box, you can email us. You can just reply to the Zoom registration email that you received and I'll pick that up. We will do our best to get around to all questions, but if we do run out of time or we don't get around to yours, please don't worry. We will try and answer them all in a follow-up email for you as well. Like all things, or a lot of things at the moment during COVID restrictions, we are at the mercy of digital. So if you do drop out or you lose connection for any reason, please don't worry. Just rejoin the event and we will let you in again. There will also be a recording of this evening's event available to watch it again. And as I say, we'll email that around to you, but you can find it across all of our social media channels from tomorrow. So if you are not already following us, please do go find us. So we're on Instagram, Twitter and Facebook. Just search for Nottingham Hospitals Charity. Last but by no means least, we are of course raising money for much needed research into long COVID, the condition and symptoms and treatment. So if you do feel inspired to support us today, please visit our website. It's www.nottinghamhospitalscharity.org.uk. Just click on the homepage banner. It's right on the front page and you can find out more about how to support us there. So all that's left for me to say now is please, I hope you enjoy the event. I'll hand over to our panel to introduce themselves and to tell you a little bit more about their experience with long COVID and our appeal. So first up, I'd like to start by handing over to Professor Ian Hall.
Thanks, Claire. So welcome everybody. So my name is Professor Ian Hall and I'm the Director of the Nottingham Biomedical Research Centre. So the Biomedical Research Centres are a number of nationally funded centres in the major teaching hospitals around England, and they're designed to do research into translational medicine. That means going from the bench to the bedside, so trying to identify new treatments, new approaches to management. And obviously we've been at the forefront of delivering some of the research around COVID and are trying to get to grips now with the long COVID problems. So I'm a chest physician by training, so I see patients, but I also undertake research in the areas related to airway inflammation in general, genetics, and increasingly in COVID. So welcome everybody.
Thanks very much, Ian. We'll now speak to our other Ian on our panel. I'll now hand over to Ian Pointer, please.
How you doing? My name's Ian Pointer. I guess the classing me as the case study. So those people out there who are suffering with long COVID or have family members who are suffering with long COVID, I'm one of you guys. I've been there and I now have the T-shirt officially to help support long COVID. It was strange. I'm not trying to get too much into it. It was strange to me to actually admit that I was suffering from long COVID. And you've also got to understand that when I contracted COVID, it was a year ago. So this is way, way back in the day when it all first started. So long COVID was just a thought and not an actual, I should imagine, prescribed, identifiable cause. So I've seen where it's been. I know where we are. I understand some of the problems that some of you might be feeling. I talk to a lot of other long COVID sufferers because of my job and because of well, basically people see me about now and know me. So if there's anybody out there with any questions, whether it be family members, how to deal with certain stuff, I'm not going to say I'm an expert, but I'll try and answer your questions as much as I can.
Thank you, Ian. Thank you. We'll next hear from Professor Charlotte Bolton, please.
Hello and welcome. I'm Charlotte Bolton. I'm part lung doctor and part researcher. My focus was just over a year ago when we went frontline. We were seeing many patients quite sick during their hospital admission. Many patients were getting better and being able to go home, but a real strong realization that that journey didn't stop then, that patients had persisting symptoms when we saw and spoke to them in clinic. And really, we need to do far more to get people back to how they were before COVID. And to do that, we need the research alongside. So yeah, that's where I got involved.
Oh, fantastic. Thank you. And last but by no means least, we are welcoming Barbara Cathcart.
Hello, welcome everybody. Thank you for attending this evening. I'm the Chief Executive of Nottingham Hospital's Charity, and I think it was me who one day said we had the help our Hospital Heroes appeal at the beginning of COVID to support our staff, and that was very, very successful. And like this journey that we've all been on in the last year, we've discovered things as we've gone along, and we started hearing these things about long COVID. And I think it was me who said to our team, I think we better do something to support that and to supplement the work that's already being done within university, as described here. And I think Nottingham is really known for expertise in respiratory areas. And this was something that was being discussed nationally, but I think Nottingham is unique in that it is a biomedical research unit nationally. And I think there is something special about a hospital charity running appeals because it keeps the research with the expertise and the experts, but local. So the doctors who are treating you are also the researchers. So it's a really unique situation to be in as an NHS charity and keeping that local aspect while knowing that you're investing in something of national and international renown. So I'm here as the head of that charity to assure you that when you hear any stories this evening and you're inspired to give or jump out of a plane or have a family member who will do an abseil or hold a bake sale, that we are here to properly look after your money and make sure that it goes to this area that you would like to support. So just to give you that level of assurance and to say that we have a whole team of people who can help you with any way that you may be inspired to give, or just go onto our website and make a donation. But basically, we want to support you locally. For the doctors who treat you, you know that that goes to them and they're doing great work on your behalf. So thank you.
Thanks, Barbara, that's great. Okay, so now we've met all of our panelists, we've got a bit more of an idea about what they can help us with. We will kick off with some of the questions that we've had sent through. So the first one is, I suppose, either for Professor Ian Hall or Professor Charlotte Bolton. The first question is long COVID contagious? And this is particularly relevant for here in the UK at the moment, as restrictions have started to ease even further. We're now allowed to be a lot more sociable indoors, and hospitality is far more open. Do I need to be worried about mixing with people now that restrictions are easing in the UK? Ian or Charlotte, I don't mind which of you wants to respond.
I'll start off then. So long COVID is not contagious. Long COVID, with the definition as we use at the moment, is really where the symptoms persist at least 6 weeks, if not 12 weeks after the acute infection, where people are contagious at the acute stage at the beginning. Do I need to be worried about people mixing with people now restrictions are easing? I think I'd argue about the word worried. I think we need to be really cautious. I think we shouldn't let our guard down. I believe we need to still keep an area of, I say, caution around it, but levels are much lower. We need to keep an eye on how things proceed and make sure that levels still remain low, and to say, take precautions where we can and need to minimise that risk individually, but also for the population as a whole.
Brilliant, fantastic. Anything you wanted to add on that one, Ian, or I can come to you for the next
Correct.
question?
I think Charlotte said it all. I mean, just a couple of comments, I guess. I think that the first is that if one has had COVID, then in theory you should be less at risk of catching COVID again, although there have been examples of people having caught it more than once. So the other issue is that one way of further protecting yourself against catching COVID is to be vaccinated. And whilst there's been, I think, some concern in patients who've had long COVID about the potential side effects of vaccination, many people who've got long COVID symptoms have gone on to have vaccination without difficulties. And it is the best way of ensuring that we reduce the risk of spread of the virus, even if you've had COVID in the past, to get yourself vaccinated. So I think, and if you haven't had COVID, then clearly you should get yourself vaccinated, because that again is the best way of cutting down the risk of transmission. So those are the only things I would add, I think.
Brilliant, thank you. I'm going to go a bit off piste here. Oh, Barbara's got a question.
Yeah, I just wanted to say something completely non-clinical, that I really appreciate what Charlotte just said about she would caution the use of the word worried, because I think that we are, the headlines are always saying, should we worry about, do I need to worry about this? Do I need to worry about that? And I think, just having your own sense of risk and safety and following guidelines is a better approach than be constantly told what you have to worry about. And so I think that was, just to pick up on that, but I really appreciated how you positioned that. No, you don't have to worry, just be sensible.
We have a responsibility for ourselves, and we also have a responsibility for the community and the population around us. So there is two elements to it, but the guidance is there. We shouldn't dismiss it, and we shouldn't just go, off piste. But we just need to be wary.
We also shouldn't worry about it. Just, be sensible, which is what you're saying. So I just want to say, I appreciate that approach. It's a sensible response.
Okay, Ian, I just wanted to pick up on your point that you said about getting vaccinated in general. This is slightly different to a question that we've had come through, but I read in the news today that there could be some evidence that having a vaccine could help diminish the impacts of long COVID. I'm just wondering if clinically, if yourself or Professor Charlotte Bolton, you'd had experience of that, or if that might be something that our attendees might have read today as well.
Yeah, so that's a really interesting question, Claire, and it's something actually Charlotte and I talked about some time ago, and I first became aware of this because I was contacted by one or two of my patients who'd got symptoms suggesting they had long COVID, who'd been vaccinated, and the symptoms had improved quite markedly, and so I went and asked colleagues whether they'd seen the same thing. In fact, there was some media attention around it. I ended up on Radio 4 talking about it, and had a lot of emails from patients. And as you can imagine, there was quite a mixture of so people saying, yes, that's exactly what happened to me. I got better after I'd been vaccinated. Then some people saying it didn't make any difference to me, and a few people saying when I got the vaccine, I had some side effects immediately afterwards. So I think there is a mixed picture out there, but we are starting to see a little bit of data from studies now. So first of all, in general, the evidence suggests that you're likely to be better rather than worse if you have the vaccine and you've got long COVID in terms of your long COVID symptoms. Although the really big studies, which will give us a definitive answer, haven't been done or haven't reported yet, I think. So I think there is something in this, and I've certainly anecdotally had a couple of patients who've said, I'm a dramatic improvement. So the really interesting question, of course, is why, if vaccination does make you feel better, is that happening? Is it just a psychological effect because it removes some of any anxiety you might have? Is it a physiological effect because it's re-altering the way the body's functioning? And one of the things that you see in long COVID is evidence of low-grade inflammation, and you can measure that in blood tests, for example, in a significant proportion of patients. And so it's possible, to my mind, that by receiving the vaccination, which produces an inflammatory response in itself, you may to some extent recalibrate the immune system in at least some people, and that recalibration could improve sort of low-grade symptoms of inflammation. Now, it's purely guesswork. It's one of the sort of things we've been looking at in some of the research we're doing, but that's my thinking about this. But it's a really interesting observation, I think, and I know other chest physicians around the country have reported similar things.
Oh, that's interesting. I suppose that's a bit of a watch this space then on the research there. I just want to say we've had a few questions in the Q&A box already, which is fantastic. So please, if you do have a question, please input it in there. You may have missed at the very start, I said we've had lots of questions already through email, so we're going to start with those, but if we don't manage to get around to everyone's in the chat, we will follow up on email, we promise, so don't worry about that. Charlotte, I'm going to direct my next question towards you, if that's okay. This one is around how people find out they've got long COVID. We talked off camera, should I say, earlier about the variety of symptoms can make it quite difficult to diagnose. So this question is asking what is the process for diagnosis to get that long COVID stamp, if you like?
Thanks, a really easy question. Not. I'm going to start off by saying, sorry to add a bit of blurriness to it, but we don't fully know what long COVID is. And I think we need to be careful that we don't clump everything together and say, oh, you've got symptoms, they're persisting, it must be long COVID. There is an accepted definition way that if symptoms persist after 12 weeks or longer, it may well be long COVID, and there are symptoms that are more classical that persist, particularly if there's several alongside, so fatigue, muscle aches and pains, joint aches and pains, this description of brain fog, memory, concentration. They may well be in this syndrome or this cocktail of different symptoms. There are various aspects to it. Some patients are making a slow recovery, and actually what we're seeing is patients making that slow recovery, having been quite sick initially. Some patients have this persisting long COVID state. In other patients, actually, some of their symptoms are because they've had an underlying condition beforehand, like asthma or heart trouble. And actually, it's that's been slightly offset, and we need to support the patient through it. So one of the key things I go with is, how is the patient and what's that recovery journey? Are things gradually getting better? Are things gradually returning? And we have to, in many ways, take each patient one by one and look at what this complexity of the symptoms is. How does it fit with what we know? Importantly, we were talking earlier, listen to the patient. And actually, I'm learning an awful lot from the patients I speak to. And bearing in mind, there's an awful lot we don't know. Mm-hmm. That certainly there isn't a list of 1, 2, 3, 4 symptoms equals long COVID.
Yeah, I'm sure a lot of our attendees here in the webinar may have experienced that. You know, it has been a case of learning as we've gone along, really, hasn't it? Especially, you know, a year ago. That's great, thank you. Hopefully this is a slightly more straightforward question. Charlotte, we'll stay with you then. We'll give you a slightly easier one. You mentioned earlier on that it can appear, you know, 12 weeks after an acute attack of COVID. How long have you found that long COVID has lasted for, particularly perhaps with your patients in your clinic? So
I guess we take flag if symptoms persist longer than 6 weeks. We classify as long COVID or of note if it lasts more than 12 weeks. That's not dismissing anyone that has it less. Vast majority of patients, their symptoms are settling or settled by 8 to 12 weeks. And I don't want to start off anywhere but that, because otherwise it's not giving a clear picture of actually the situation for the vast majority. That said, for those where those symptoms persist longer, it can be concerning, it can be worrying for them, and they need some answers. So it's the balance of the two. How long have I known symptoms last for? Well, I guess we've only got 14 months history, and not everyone is back to how they were. However, again, I've seen an awful lot of patients have symptoms at 3, 4, 5, 6 months, but give it another couple of months and actually their symptoms are far more improved.
Okay.
It is that gradual improvement over time. I probably started off last May by saying, oh, it could last a year. I think I'm having to be stretch that a little bit more now.
Yeah.
As we learn more. But generally, symptoms improve over time, and we know from previous coronaviruses 10 years or so ago that it can take quite considerable time, but people do improve over time.
Okay, we will move on to Ian Pointer, if that's okay, if I can come to you. I think if you could just unmute yourself, that would be fab. Ian, I wanted to ask you, obviously you've experienced COVID, long COVID yourself. I know we're talking, last year, and thank goodness you're much better now. But one of the questions that we've had is around, I suppose this sounds like it's come from someone who a loved one has experienced long COVID, and they're thinking, what can I do to help? I don't know how to support this person. What helped you when you were experiencing long COVID? How did your friends and family rally round?
That's a really tough question, isn't it? It is literally just being there to support and understand it. My situation was, we get the fatigue, so I had the fatigue, and we get the breathing issues. You can build on that to a certain extent. Fitness levels, little walks help me do that. The anxiety and the mood swings are where, if you're looking after somebody who's suffering from long COVID, I guess my partner's laughing in my corner of my peripheral vision. You have to be a little bit kind of, it's not his fault, if you know what I mean. It's not his fault. Don't blame him. They just don't realize what they're doing, and I didn't realize what I was doing. I didn't realize how snappy I could have been. I didn't realize how depressed and quiet I could go. So it's just being with them, not just rally around them. That's all you need, is to be a supportive role. So, and that's what helped me. Rather than, I don't want people cuddling me and giving me the attention. Just want them to be supported and let me come out. If I got into a funk, just let me come out of my funk in my own way. Don't try and keep on asking me what's wrong, because you're just going to send me down that rabbit hole again. Just let me come out of it my own way. That was it. And she's killing herself with laughing now at the fact that I just said that. But yeah, just be with them, help them as much as you can. Whatever it does, whatever puts a smile on their face, whether it be just take her for a walk or buy them a pint, just whatever it takes, just put a smile back on their face, and they'll come out of that funk and help them out.
Yeah. Oh, well, even if you don't feel like that is particularly specific, I'm sure that will help some people listening. So thank you. Ian, if we could stay with you for the next question. Oh, actually, no, we'll go to Barbara for the next one, if that's okay. This follows on from what we were talking about with Ian, actually, about, if a loved one's experienced COVID, if a friend or family member is experiencing long COVID, is there anything that they can do, especially if they're based in Nottingham, in order to support the research which is going on right now?
Yes, if people would like to help support the research and fund the research, then they can make a donation or inspire people to do things to be sponsored that could raise money. So that could be anything physical or anything, make crafts or have tea parties or run marathons or climb mountains, or just to get sponsorship money. That's through Just Giving that would come to us, or just make a straight donation, and just be specific that you would like to fund local long COVID research. And I think, as I say again, what we're talking about here is the doctors treating you are the ones who are going to get this money, but they're not just like, they're doctors that are connected to a national network. So although it's taking place locally, it's still very much peer-reviewed, national funded research. So yeah, that's how you could help. There's a lot of information on our website, and as I said before, teams of people who will help. And just like Ian, you know, they'll just take you on the journey with them, or he will follow you around and do what you need. I think Ian could probably, I think Ian himself and his supporters have raised, I think you were saying £2,000. So maybe you could describe what that was like for you, what kind of help you had and the ideas you had to help, because that's a good level of contribution. We're very grateful for that.
We did a fancy dress day in my own little, I'm a postman by trade, and in my own little delivery office, we did a fancy dress day. They did it while I was in hospital, and we're going to make it an annual event, whether the money goes to your charity. Well, it will always go to the NHS in some way, shape or form. We made it an annual event. I think on the day we raised around £600, £700, £800, sorry. But prior to that, I basically just asked, borrowed and begged everybody to give money. Whoever I bumped into in my profession, I just begged, borrowed money from them. And I've still got a lot of outstanding debts to call in as well. So that figure will get higher, trust me.
So you could say, here's your mail if you give me a donation.
Yeah. I like your idea.
Ian, if we could just stick with you then, what has been the motivation for you? It's maybe an obvious question, but why did you want to, you're much better now. I know we're not 100% there yet, but you're feeling much more like yourself. What has been the motivation for you to support this, to get involved with this webinar, to work with charity? We can see you are absolutely rocking the Nottingham Hospital's charity t-shirt today.
Well, like I say, when I was in hospital, we did a collection locally, but also nationally for the union I'm a part of. I think we raised, ironically, probably more than you've got in your pot now. But that went into the NHS Trust and disappeared into that big ether. So, but when I came out, it's part and parcel of my makeup. I've always been a fighter for causes. I wanted to pay back the NHS, and I told Charlotte this when I spoke to Charlotte seems years ago now, but months ago, that I will do anything for the NHS because I owe you a great gratitude for basically saving my life, because I was in a dark place and a really bad place at one point. So I'd do anything I could. And I can't remember who got in contact with me about the long COVID. And I thought, right, I'm here. My personality is I fight. I've proved that I can fight. I will fight for those people who are on this webinar who are now suffering for long COVID. I will be your spokesperson. That's my personality. I will go out and I will get that money for you. I will drag anybody screaming, shaking them by the heels to get money out of them, because we need to get this research done, because we need to understand what the problem is. Because I don't want long COVID to be the next pandemic. I know it's a strange statement, but we don't want it to be the next pandemic. We don't want people suffering like this long term for time, for years and years afterwards. So we need the research. I'll go and grab the money from somebody. That's the way I do it.
Thank you, Ian. Okay, so we'll move on to Professor Ian Hall, if I could come to you next. This is about the research that's being done in Nottingham, or that we're hoping to do in Nottingham, that we've got this appeal to fundraise for. I'm sure lots of people will have seen in the press that there've been a number of long COVID research projects which have been announced after hours, I should say, but there's been, some national funding committed to it. But what makes our research or the Nottingham research different to the national research, would you say?
Yeah, so I think that I'm going to ask Charlotte to sort of comment in a minute, because we've got some particular expertise which she is better placed to talk about than me. But I think a couple of things. So first of all, Nottingham has been to some extent ahead of the game, I think. So we recognised long COVID to be an issue before there was any structures around services or early research, actually, and started setting up programs looking at describing what the condition was, and most importantly trying to think about what interventions might be effective in helping to care for the patients. And I think so the first thing that was very clear, as Charlotte's described, is that there's quite a mixture in terms of the symptoms and indeed the physical evidence of disease that people are suffering from. And so clearly one's going to need to have a multidisciplinary approach. So that's not just a doctor giving you a tablet. You need to have a range of different approaches. You know, if you've got significant psychological issues, you may need support with those. If your problems are more to do with mobility and phased exercise, you may need a different sort of approach. So we were very keen that we set up what's essentially an individualized, call it personalized medicine approach, if you like, where the solutions were designed to be fitted to the single patient. That's slightly different from some of the national work that's going on. So I'm involved in some of the national studies, but they're, I think, more longer-term descriptive, where you're getting very large numbers of subjects and saying, on average, how many people have got lung fibrosis or whatever it happens to be. And so they've got a slightly different focus to what we're trying to do locally. Now, one of the things Nottingham is particularly known for is its imaging research. As I'm sure many people listening will know, that Sir Peter Mansfield got the Nobel Prize for his work on magnetic resonance imaging, or MR imaging, whilst he was based in Nottingham. And we still have fantastic imaging facilities here. So a lot of the projects we're doing locally are involving imaging, because that's one area where we've got the international expertise which we can contribute that a lot of centres might not have. So I'll stop there, but I'm sure Charlotte might want to add a few things about the areas that she's particularly got expertise in.
Yeah, thank you. So yeah, just to add, as Ian Hall said, a lot of the large studies have reported that a certain proportion of patients have persisting muscle aches or fatigue. But really what we're focusing on in Nottingham is the why and the how. Why are people suffering with persisting fatigue? What's causing that? And utilising some real key mechanistic work to answer that question, so that we can then, far more importantly, work out how to treat it. We do take an approach of treating the patient in front of us, the person in front of us, and we want to do everything we can to get that person recovered fully and as quickly as possible. I believe very firmly that across the group of clinical doctors, nurses, physiotherapists, psychologists, we're doing everything that we know we can, but there's a lot we don't know. And actually the time is now. We can't wait a year for a big grant body to give us a grant. We actually have people coming to the clinic in their droves at the moment with persisting symptoms. And I say we can do what we can, but there's an awful lot I don't know. I don't know the best rehabilitation regime. I don't know the best exercise or the best elements to piece together. And that's what has driven us to try and answer the why question. Why are these persisting and what can we do about it?
Mm-hmm. Okay, brilliant, thank you. We've talked already about the vaccine and the impact of that, so I'm not going to touch on that too much. We have had, and we are getting quite a lot of questions which are very specific when it comes to symptoms, and I know we've touched on this already, but it isn't just one symptom equates to long COVID. There are so many different ways that this condition seems to be affecting people. One question that someone asked us was, does having COVID-19 put you at risk of other conditions later down the line? And this person in particular mentioned stroke as a potential. I'm wondering, either Charlotte or Ian Hall, if either of you had seen that kind of issue raised.
So I think there's a distinction between COVID and long COVID here. So if you have had a severe episode of COVID, significant enough to put you in hospital, possibly significant enough to put you on a ventilator on in intensive care unit, then there are some inevitable consequences of that. And the other problem is that people who had more severe disease tend to be those who already had pre-existing medical conditions. So first of all, pre-existing medical conditions could be made worse. So people who had some heart failure, got COVID, their heart failure might have got worse as a consequence of that. Similarly, some people who didn't have pre-existing cardiovascular disease may, as a consequence of the COVID, have developed it. And so I think that's related to a severe attack of COVID in the first place. People who had much milder COVID were much less likely, I think, to have long-term sequelae from that. As far as the question about stroke is concerned, I mean, Charlotte might want to comment as well, but I'm not aware of any evidence to suggest that if you have long COVID and you didn't have a severe episode of COVID which precipitated it in the first place, you're at increased risk of stroke compared with anybody else. There's some evidence if you had severe COVID that you're at increased risk of clotting episodes in the period of time immediately after a discharge. That's not just stroke, but other things like deep venous thrombosis. But again, I think that relates to the inflammatory response with the severe disease rather than with the longer term COVID. So I think that the bottom line is that if you had COVID in the community, you didn't end up in hospital with it, you've been left with some symptoms of long COVID, the likelihood of you having a serious complication like stroke, etc., is very low.
Okay, that's great, thank you. Carrying on with the variety of symptoms, if you like, and the very symptom-specific questions, we've had a couple of people mention symptoms which we don't talk about as often as things like muscle fatigue, breathlessness, etc. We had one individual mention a buzzy feeling in their head or numbness in their hands and feet. They said it was very different to brain fog, so I don't know whether this person had that as well or if they could just you know, differentiate between the two. But Charlotte, I know if we come back to you, I know we mentioned earlier that the symptoms are so varied. Do we know why they're so varied yet, or is that part of the research that we're looking into?
We don't fully know why they're so varied. Different symptoms are prompting people to present to different doctors and teams as well. I think that's where some of the bigger studies can begin to piece together some of these symptoms that aren't as common and try to understand if there's clusters of symptoms in certain patients and why certain patients are at risk of those symptoms persisting. Some of them are very difficult to describe. That doesn't mean we don't believe the patient, but it can be quite challenging to get further to understand why. And again, it comes back to what's being caused directly because of the infection and has persisted, what's caused because of damage, what's caused because of the life-saving treatment that people needed at the time of having the acute COVID. So many patients did need intensive care. Intensive care was life-saving and everything that involved, but actually because of it, it's caused a bit of sort of peripheral damage, and what needs to be researched. And I guess I'll finish on the research bit, which is, you know, just as we're studying certain conditions and symptoms, others groups are looking at persisting symptoms in other ways. This buzzing feeling, I've heard many patients report, the numbness in the feet and hands, again, is quite common, and whether there's persisting circulatory changes, whether there's persisting nerve changes or damage, there's so much we don't know.
Yeah,
so much we don't know.
Okay. We had a question on Facebook actually, which I'm going to jump to next. Ian Hall, if I could come to you for this one. Charlotte, again, you might want to also answer. We had a couple of people who have experienced other conditions, not long COVID actually, but are, I've sensed a degree of frustration that perhaps there is now funding into long COVID when there are other long-term conditions which, you know, do get research. But I think that the person who got in touch with us was asking if the research we're doing will help contribute towards the treatment or the understanding of other conditions as well. So this particular individual mentioned that they had ME. We've heard of a couple of people who've had, you know, chronic fatigue or other post-viral issues. So I'm just wondering if either of you had any thoughts on that.
Yes, I'm very happy to comment on that. So I think the medical profession in general has not done enough to try and define conditions such as chronic fatigue syndrome and its underlying pathology. It is challenging. They're not easy conditions to study, but I think one of the things that will come out of the COVID pandemic, and in particular the number of people presenting with long COVID, is a better understanding of these other post-viral syndromes. It seems to me extremely likely that some of the mechanisms which are important in long COVID also apply in patients who've got chronic fatigue syndrome, for example, whereas some others will be more specific. Now, because we've had so many people who've had COVID, then obviously there's a lot of long COVID around, and so I think it's inevitably drawn more attention. You know, in an average year in the UK, you know, flu causes a fair number of illnesses, and some of those people go on to develop some long-term symptoms, but they tend to get ignored, I think, by the medical research fraternity. So I think that, if nothing else, the vast amount of information we're going to learn about long COVID may well pay dividends in getting a better understanding of some of these other conditions, such as ME and chronic fatigue syndrome. And I think perhaps, hopefully, more acceptance that these are real conditions which cause real suffering for patients.
Anything to add from yourself, Charlotte, on that one?
Totally agree. I think the other thing that we're coming out of COVID recognising is the need for this recovery and the need for the research into the recovery. So for quite a few years now, we've known of persisting fatigue after a common reason for admission being pneumonia. We've known that patients can take several more weeks before they get back to work, before some of those symptoms such as fatigue, cough, breathlessness improve. For many patients that were in hospital with COVID, they had a pneumonia, an infection within the lung itself, and that's the symptoms persisting has been brought to the forefront. So I'm really keen that one of the key lessons, being constructive and positive coming out of this, is that we actually apply some of this to other common reasons for admission, so that we can begin to understand far more how we can improve that recovery for other reasons for coming into hospital.
Brilliant.
Recovery side.
Okay, we're going to go to some questions that we've had sent through now. I will give a time reminder. We have got just over 15 minutes left of today's session, so there's still time, if you're quick, to pop a little question in the Q&A. Otherwise, of course, we'll get round to it. The first question, and I will keep this anonymous for our attendees. One individual has commented that they've had a sore throat. They've called it a kind of inflammation in the throat since catching COVID in March last year. So this sounds like the first wave. They've asked how common that is, what could be causing that. Charlotte, is that something you've seen in your clinic?
Yeah, I mean, absolutely. So the clinics I've been doing are on a number of different levels. We've followed up an awful lot of patients after a hospital admission, but also taken new referrals where patients didn't need admission to hospital, often had quite severe symptoms, but didn't need that hospitalisation, but then have got persisting symptoms. It struck me and the team quite early on last spring. And I do remember commenting to one of my specialist nurses saying, there's quite a few people reporting this sore throat. Have you come across it? She said, oh, I've just had the second one this morning as well. So there doesn't seem to be any, it does seem to recover over time. It doesn't seem to be any obvious damage as such, but it certainly can be quite disturbing for the patient with that symptom. It can certainly obviously not help with communication when a patient's trying to relay what's happened to them as they recover from COVID. I couldn't put a number on it, but it's certainly a common symptom that, you know, really came out of the blue. Yeah.
So this person isn't on their own. I think that's what we can, you know, emphasize.
Absolutely.
It's great. I'm just going to stay on that thread actually of clinicians believing patients and believing the kind of symptoms. We had another question in the Q&A, which it was quite specific in terms of their condition. So I will. It's probably easiest if we get back to them individually with if there are some specifics. But what they did mention is that their issues that they're experiencing, and it looks like specifically breathing issues, they're finding it very frustrating that their clinician doesn't seem to believe that that's what they're experiencing. I'm just wondering if either of you want to comment on that. You can imagine the symptoms are so varied. We don't know everything about long COVID at all yet. What would your advice be maybe to people who think that they might be going through something like this? Is it to try a different clinician? Is it to seek support groups online? Perhaps a difficult question, but I quite like to acknowledge it a little.
Yeah, so that is difficult to answer, isn't it, really? So the first thing to say is that I don't believe as a doctor we know everything about everything, and if we and I guess as a profession we have a bit of a fault that we do tests, and if the tests are normal we say, well, there's nothing wrong with you, off you go. Obviously, if tests are normal, it's reassuring that we can't pick up evidence of major structural damage in, whatever. So if we do a CT scan, for example, and the CT scan's normal, we can say, well, there's no evidence of severe structural lung disease. That's obviously reassuring, but it doesn't belittle the fact that somebody might still feel breathless and I think perhaps as a profession we have a bit of tendency to say, your scan's normal, off you go, there's nothing wrong with you. So it can be challenging to get to the bottom of things. So sometimes it's, I think an element of reassurance is useful. If tests are abnormal, then that obviously points to damage in an organ system, and it's much easier to be able to explain people's symptoms. But there are plenty of people out there who I think have got symptoms which are entirely genuine, for which we can't find an obvious explanation. Coupled against that, obviously what most people want would be treatment. So, here's a magic tablet which is going to take away whatever that symptom is. But the problem is that most medicines that we use also have side effects if they work. And so there's this other issue we have to balance, which is we should not be causing harm unnecessarily to anybody. So just treating patients without any objective evidence of disease is actually quite difficult. So I think one just has to keep an open mind, and sometimes the only thing you can do is use a period of what doctors sometimes call watchful waiting, which is sort of keeping an eye to see if things develop before making a firm decision one way or the other as to what the right thing to do is. But I understand that's very frustrating for patients who have got a symptom which they're convinced is real and we can't explain. But I'm afraid that's part of the job we have to do.
Yeah, okay, fantastic. We've had, and I'll go to the next question. So we've had one question about long COVID neurological symptoms, and in particular things like numbness, tingling, a burning sensation. None of those sound particularly pleasant, do they? Is there a hope that they would go away? What is the most common way of diagnosing those sorts of neurological conditions? So maybe Charlotte, if we go to you about the neurological side of it, is that different to the more, I suppose, physical symptoms, if you like?
So I guess I'd class these as physical symptoms. They're slightly more non-specific, but they are certainly physical symptoms that people experience. There is, as Ian was saying, with the breathlessness side, I guess there's different levels, and as doctors we certainly don't know all the answers. What we can try and do is try and rule out anything of major consequence or anything that needs specific intervention, but often we're left with persisting symptoms, and we can offer a layer of reassurance, and again believing the patient without knowing fully why that symptom is persisting. Again, numbness, tingling, burning sensation are quite common symptoms. They can be for a number of different reasons, a variety, which I won't go into a whole host, but by spending some time discussing what the potential causes are in that person can often identify some routes to try and at least settle things down slightly. There can be an element of additional psychological element to it, and that doesn't mean that I'm saying all of it is psychological, but actually there's nothing like uncertainty to drive concern in persisting symptoms as well, and the two can go hand in hand, whether it's COVID or whether it's something else. So we work with the patient to again say reassure with what we can, identify what we can to try and resolve and settle things down, identify any potential causes, and yeah, take from there.
Great, thank you. I did put you on the spot a bit there, Charlotte, so thank you for answering that. Let's have a look at the next question. Okay, Professor Ian Hall, let's come to you again for this one. Would this particular individual's asked about managing chronic fatigue, how they manage that, how they deal with that as an issue. I can imagine that must be quite a debilitating part of long COVID, especially as life is trying to get back to normal. People are working jobs, looking after families, etc. Any tips or advice for them?
Well, first of all, a bit of reassurance in terms of long COVID. The vast majority of people I've seen, as Charlotte mentioned earlier, who've had long COVID, who have had problems with longer term fatigue, it has gradually improved over time. And it may take a long time, so it might not just be 12 weeks, it might well be 9 months or longer. I've certainly got colleagues actually and patients who still have sort of day-to-day variability, but in general the trend has been a gradual improvement. I think, and again, Charlotte might want to comment on this because I know it's an area she's worked in, but in the past there has been proposals to have, rigorous exercise programs in people with these with sort of chronic fatigue. My reading of those sorts of approaches is that in general they're not helpful. In fact, if anything, they're worse than sort of doing nothing, because they actually are slightly punitive and make people feel bad. And so I think that what's critical is to have a graded program of rehabilitation, taking into account the inevitable day-to-day variability that people have. So on a good day, people can often feel they can do a lot, but then they'll have a bad day, or and then obviously they need to be able to do less. So Charlotte's more of an exercise expert than I am, but I think it isn't helpful to say, pull yourself together, off you go and do 2 miles today, 4 miles tomorrow, and 6 miles the day after. So I think it's that sort of moderated approach, taking into account the individual feelings. And I notice Ian's got his hand up, so he's either going to disagree with me or agree with me, hopefully.
I'm going to agree with you. Yeah, my fatigue levels, being a postie, kind of relatively fit, I can still only do maximum 4 miles now on a walk. But what I learned was baby steps. If, like you rightly say, if you feel like you can do it, then do it. But if you do too much, you will pay the following day. You will pay the following day. So little baby steps, set yourself little targets, try and just keep on moving forward. It might be just a walk around the garden today. It might be a walk to the shops tomorrow. But if you don't feel like doing it, don't do it. It is all I can say. It will get better, but little baby steps is what you've got to do.
I think, really eloquently said. For many of my patients, they were fit and healthy before they got COVID. The frustration of not being able to do that after COVID as they recover can be immense. And therefore, when they have a good day, they want to make the most of it. And many report overdoing it, which is human nature. And I've sadly learnt the hard way of how it's offset them, and actually had a number of days recovering from what would have been very simple exercise before all this and before they had COVID. So it is listening to the body. It is taking those baby steps, as Ian said, going forward. It's not overdoing it. There is no right or wrong prescription exactly of how much somebody needs to do. It is taking good, healthy care of yourself as well alongside. And it's giving yourself time. For many patients, again, postman is a good example, but for many patients, actually their work requires a considerable amount of exercise and activity. And therefore we've worked quite hard with addressing employment and people's return to work so that people don't race back, or that, more importantly, employers don't expect people to be racing back. You had COVID 2 weeks ago, come on, come back. this is taking time, but we need to be in it for the long run and getting patients back, you know, investing in the patient and their full recovery.
No, from speaking to you before, Charlotte, this does not seem to affect the same sort of people that COVID affected either. So you might get an individual that you know, was running marathons before, and then, you know, a peak of physical fitness, and then now, you know, as you say, Ian, can't walk to the shops without getting so breathless. So I think great advice from all three of you. Thank you. We'll move on, which is another question from the same individual. Actually, they've asked around again another symptom-specific question. Charlotte, if we could stay with you, this is about nausea and dizziness. If you've noticed the occurrences of those within your clinic.
So a lot of patients report nausea and dizziness at the time of having COVID. For a small proportion, they report particularly the dizziness persisting. But it's probably, in the clinics that I've been running, I qualify that, it hasn't been a significant symptom, but it's certainly been there in a number of patients. So it's not ringing outside of many stories that I've heard. Again, the reasons behind it is important to me. And I know that some other colleagues within the university are focusing and interested in the dizziness side of things and trying to understand the why and what can we do about the dizziness. But in the clinics I've done, it's been far more common symptom at the time of the acute infection than persisting. But yeah, it can be absolutely troublesome and affect quality of life. And just to go back to what you said before, certainly many of the patients who didn't need to come into hospital have overwhelming symptoms ongoing. Many of the patients that we had really quite severe admission to hospital actually made a very good recovery. So there is no full rhyme or reason behind that. And that's why, again, it has to be a patient-based approach as to what the symptoms are and listening.
One of the things I would just sort of say is that because so many people have had COVID and the symptoms of long COVID in particular are so variable, there is a little bit of a risk that people may actually have developed another condition without realizing it, just coincidentally. So one of the things that we're starting to see now in the NHS services is people presenting later with other diseases, which people may have put some of the symptoms down to COVID initially, but actually turns out to be something else. You know, a whole series of things. But we're particularly worried about symptoms which might be suggestive of cancer, for example. So if somebody had a lot of weight loss and some diarrhea, well, diarrhea has been reported in long COVID. Some people lost some weight. But I think what I would say to anybody who's listening is that, sure, if you've had COVID, symptoms might be due to long COVID, but if they're not getting better, and if you've got any particularly other warning things, don't just automatically assume that everything's long COVID, and do contact your medical practitioner and get advice, because what we don't want is to see people presenting late with diseases which we could have treated if we'd have picked them up earlier.
Ian, I think that is a great point to end on, actually, one of optimism and reassurance, and that our NHS is there for us, our medical professionals are there for us. There are a couple of questions that we've not managed to get around to, but as I say, we will respond to those individually. If you've listed your name, we can get in touch with you afterwards. So thank you for all of your contributions and for listening as well. I do make it almost a minute to 6:30. So we have come to the end of today's panel discussion. I just want to say a massive thank you to all of you for taking the time to join us this afternoon on behalf of Nottingham Hospitals Charity and the NIHR Nottingham Biomedical Research Centre as well. And of course, Ian Pointer, our marvellous case study. Thank you very much. We hope that you found this really useful and interesting. Please keep your eyes peeled on our website. We will be doing a follow-up blog with all of those questions on there, so you can read back and watch again. And last but by no means least, if you have been inspired to support our appeal, I would love it for you to visit our website and take a look at our appeal page and do make a donation. We are well on our way to our £50,000 target, but every every donation, no matter how small, will help our researchers understand more about the condition and crucially help improve treatment for patients here in Nottingham and across the UK as well. So thanks again to all of our panellists for taking the time to join us today. You've all been magnificent. Thank you very much. And we look forward to seeing you at another event in the near future.
Thank you.
Bye.
Thank you.